And we are pleased to have, of course, Cathy with us, Dr. Cathy Bennett-Santos, veteran, author, and founder of National Alliance for Women's Veterans, Inc. How are you?
I am well, sir, and yourself today.
Doing very
Great
well.
shows.
Thank you
Yes, sir.
so much. Thank you so much. Wanted to talk about the veterans' obstacles addressing the lack of equal access to quality health care. Uh, what you're an expert on this. What do we need to know about this?
Today is Cervical Cancer Awareness Month, and I would like to just kind of recognize that and just kind of urge any of the women listeners to get that test. They have a preliminary test on the cdc.gov website just to get some information and to alert them to some of the indicators and risk factors that are involved with cervical cancer. So I think that was important to note as a start here on today's discussion. I believe many of the challenges today are being addressed. The prior guests, I thought they did a phenomenal job in talking about some of the new and improved services. Certainly, I am witness to that. I did want to kind of share a little bit about the Veterans Healthcare Administration. That is the integrated service network that governs all of the healthcare in this phenomenal institution for veterans' health delivery system. It comprises 1,255 healthcare facilities, including 170 medical centers, 1,074 outpatient sites, and it serves approximately 10 million veterans enrolled each year. One of the challenges that I see, they just introduced the Missions Care Act, which they, I believe, have the intent to provide additional services for veterans who may not have easy access, to extend to some of the community-based programs that would include some of these kind of satellite service provider centers where the veterans can have easy access and to address the influx or the overflow of some of the this institution's, I guess, a influx of veterans. I think there's a new and improved veteran service delivery system, but I think there are more veterans now who are enrolling. And I think with that challenge comes, you have a lot of third-party vendors who provide services. Many, I do believe, may not have the necessary vetting or oversight to ensure that that veteran is getting the same care. What I am hearing from some of these third-party services or vendors that are delivering services, for instance, dental or other mammograms or that type of a thing, there are veterans who are dissatisfied. They're offering acupuncture as an alternative treatment. In their holistic approach to dealing with veterans' care, I believe that some of the challenges is they're not specific as to what is actually veteran-related care. And I think they need to be more distinct in that analysis as to what that veteran experience is. And I think what my challenge has been in my articulation on this week here in Philadelphia has been that, are you listening to the veteran? Mm-hmm. And I believe that with all of the delivery systems, we have to make sure that the actual care is intended for someone that they have recognized or combat-related, military-related, or something that they have determined from some other source. If I may just take a break and allow any questions, Mr. Kelly, but...
No, go right ahead. Yeah, you're saying a lot. Go right ahead.
Yes, sir. Mm-hmm. So I think that we should be concerned, just in our previous guest spoke about the banking program, the bank benefit program. For me, I would challenge that just a little bit because I think a few years ago they started the fiduciary program, which was determined by their mental state or whatever that mental health provider had determined their capabilities was. So that fiduciaries in some instances were put in the hands of a significant other, or in the that fiduciary became a banking institution, and sometimes that veteran was very capable of managing their own finances. My challenge with banks as a secondary institution having control or to monitor or even having access to one person's individual banking habits in that, or to be able to, for me, presents a challenge as to why that has to be. I think a veteran should have that option, and that should be determined very closely with the veteran's input as to who should govern how they would like to govern their own finances. And I think that for me on that particular issue. But healthcare in and of itself, I believe we're going in the right direction.
Okay.
We have in Philadelphia, and I'm going to challenge Chicago on this. I believe we have the best.
Okay.
So what I do know is that we have a wonderful female director here at the Philadelphia VA. I believe that she is phenomenal. She's a retired nurse admiral with the Navy.
Oh, wow.
Very, very concerned and compassionate leader in her directions, in her supervision, and in her healthcare strategies. I believe that she presents that for us. We had a town hall meeting here in Philadelphia this week, and I think it was phenomenal for engaging the veterans. She wanted to know exactly what was on the minds of the veterans, and she was very, very sensitive in addressing every one of the comments on complaints. It's a very professional dialogue, but many of the complaints, I believe, are synonymous with what's happening across the board, in that the compounded issues that is happening prior to this new approach, whether it's the Mission Act or under the Obama administration, they had the Accountability and Access Act in 2014. I think we're moving in a direction that will still take some time for it to manifest into the lives of us as veterans. So this conversation allowed the veterans to speak about those things that they were experiencing. I will tell you that the challenge for me with the information that the OIG is putting up, phenomenal information on doing impromptu inspections in these VA hospitals. They are being very honest about what they're finding. One of the issues that I found that they have discovered was that sometimes the processes are flawed for getting the care to veterans timely, particularly in terminal illnesses when diagnosing cancer, which is why I wanted to talk a little bit about the psychosocial screening distress for oncology. It's a tool that they're using to measure some of the stresses that are involved when patients have been diagnosed with cancer. 2 cases it was based on there where these particular patients committed suicide in the parking lot of the hospital.
Wow.
And it was a question by the OIG, were these patients screened for their distress level in their psychosocial screening process? And with the mounting numbers of suicide victims, I would question that particular investigation was done because of the compounded issues over the many years where many veterans had not attended the VA hospital. And I do believe that there have been compounded medical issues where now that they're finding out they have terminal diseases, they have conditions that are irreversible, whether it's cancer or other terminal illness, and then they're committing suicide, because they have no alternatives to their health care after seeking it for so many years. So I think that the OIG has done a great job, and 2 reports, and I can make this accessible to anyone who wants them. There was a report done in September of last year that speaks about the state of veterans, and I believe that's a very good description on the 5.1 miles of backlogs of claims. It helps us to understand where we are in this process. So, Mr. Kelly, I do believe that this program has really been an enlightening platform. And for me, I am just delighted that I can share this vast knowledge that I myself have been privy to, and helping people to understand that we are moving forward, getting there and get the care, because I do believe we are in a different place today as of yesterday. And we must begin to really understand what has happened in the delayed appointments, why the scheduling issues existed. And another report that came out in December, it spoke specifically to the training, and it talked about some of the ineptness and incompetence of some of the residents and the staffing.
Wow.
But we are not taking excuses for that. I believe that we must be diligent in holding people accountable, because I think too many veterans have suffered for far too long. And I believe that we're in a good place now to have this discussion and make sure that we are addressing realistically what has happened over the many years where veterans have been disconnected from the care that they have needed. And we welcome the new and improved veterans and the new director, and as well as the secretary who has been visiting these hospitals. I think he is very sincere in resolving as much of these problems, and I'm very supportive of the new leadership that we have, both in Washington, D.C., and certainly through our local networks of veterans in my research as of late.
We're certainly pleased to hear that, and we are also pleased, Doc, with what we have here in Chicago. The VA in Chicago has been doing a great job. Listen, as you know, of course, January is Cervical Health Awareness and National Blood Donor Month. Is that could the blood situation have anything to do with this, or is that just coincidental?
Mr. Kelly, I'm going to reserve a comment on that at this point.
Okay.
I'm very, very cautious as to the level of complexity in what I learned, and I do not believe everything is appropriate sometimes for all audiences. Mm-hmm. So if you don't mind, if there's a discussion that we can have at another time, I believe that you have a very, very mature audience in what I'm hearing. But some of the conversations around research and many of the other more complex scientific platforms, I think is a little bit discreet, I believe, in how they should be disseminated, some of the information. So we should have that discussion at another time.
Well, that's whatever you say, Doc. That's fine. That's fine. You know more what to do than I do. That's for sure. We're just pleased to have you with us and giving us all this great information. What else do you think we should know?
Well, I really thought that was important to talk about. One thing I thought was important to talk about was when you talk about from an African American perspective.
Great. Mm-hmm.
Of course, that is my research, and I think we're going to be doing more specific talk about research in the future.
Right. Mm-hmm.
But I do believe that where we are today on research, we should be concerned that the ethnic and the racial disparities are consideration. So I'm really focused on morbidity and mortality with regards to how they are reporting on that through the VA systems. So whether we have a percentage of African Americans who have suffered from breast cancer, cervical cancer, we need to be more specific about how that information is being shared. I think it is important that we are able to identify where those vulnerabilities are and identify the risk factors. We're doing a great job, but as far as the information, I think that it should be more readily available, particularly when we're experiencing those types of things, to understand the processes by which the VA has now implemented to help save our lives. So with regards to the morbidity and the mortality of some of these conditions by which the VA now have identified as being prevalent in veterans, I do believe that we should be accurate in analyzing how they are adversely affecting the African American, I think, which in most cases, predominantly the social economic challenges that African Americans face seem to be an influence as to how we are responding to that, if you understand what I'm saying. So where they are presenting many of this data, and we know that if the socioeconomic conditions or the transitioning conditions of a veteran impacts their access or these different things, that's a very specific space where we can focus. Let's address that issue. So my research certainly addresses those gap analysis where there is no particular dialogue as to how a certain population can actually be identified or recognized for having a certain condition of, and so why we're not focusing on that, and why we're not bringing that issue to the forefront in a way where we know our vulnerabilities when we are dealing with people in urban. My issue is urban. Conditions, or more of the African American communities where you may find disadvantage. I think that we should be very serious about being in a particular group that have been identified in that capacity. If you can understand, I'm trying to use